would just like to inform you all that it's our proud privilege that we have been joined by Dr. William Trattler, and he is a renowned refractive cornea and cataract eye surgeon at Center for Excellence in Eye Care at US. In addition to his private practice, he is also on the volunteer faculty at the Florida International University, Wertheim College of Medicine, as well as the University of Miami's Bascom Palmer Eye Institute. He is involved in so many projects, has received so many multiple awards, and has been involved in treating corneal diseases, especially ectasias, post-classic ectasias, cross-linking, etc. So it's and of course we have been doing webinars with Dr. William Trattler earlier at the AIOS level during the COVID time. So we welcome Dr. William Trattler, and we would like to have the video that he would like to present. So a very warm welcome to you, sir.
This is a progressive disease.
So what time is
that? But it's actually much more common than what was once thought. And the key is that if we identify keratoconus, we can actually perform cross-linking to stabilize the cornea and prevent progression. But it can be difficult and challenging to identify keratoconus early. Here's an example of a patient that looks pretty normal. They had a topography. Maybe they're coming in for a refractive surgery consultation. They have just some slight inferior steepening. Not enough that would make this patient truly classify as keratoconus. But the patient was followed over time. They were in their 20s. They came back 2 years later, and now there's been a change in the shape of the cornea, where the steep part of the cornea got steeper, the flat part got even flatter. And this actually, now this patient has developed keratoconus. The difference map shows us clearly this change that occurred over these 2 years. So this patient could still be a little difficult to diagnose, especially in 2014. 2016, also, even though on topography we pick it up, but they may not have had any findings on slit lamp exam. So how common is keratoconus? Well, we all remember the number of 1 in 2,000, but more recent studies have found that it's much more common. This study from the Netherlands found it was about 1 in 375. And here are studies from multiple other countries where the incidence or prevalence is, sorry, I meant to say prevalence, is about 2 to 3%. And then it's as high as almost 5% in Saudi Arabia. So again, much more common than what was once thought. But one of the challenges is that keratoconus is often discovered late. The slit lamp signs of keratoconus are often only visible when there's moderate to severe keratoconus. And often significant keratoconus can progress or develop prior to vision loss. So this is really interesting. I've seen a number of patients, and these are not all of them, where these patients have obvious keratoconus on pentacam or slit lamp or on topography or tomography, whichever technology you're using. And you can see they have keratoconus here, but their uncorrected visual acuity in all 4 of these eyes was 20/20. I have other examples of just like this. And they're seeing reasonably well, so they don't come in for eye exams. So it can be tough to diagnose in early keratoconus. Now, once we do diagnose them, it's really critical that we consider cross-linking early because patients can be quite progressive. This young patient progressed from January to April 2014. The Kmax got steeper, and you can see from the difference map that the steep part of the cornea got much steeper, the flat part got much flatter, so the irregular astigmatism worsened and their vision, unfortunately, declined because of this progression. So we want to catch this early. Now here's a patient in their late 40s. Some people say that once you're over 30, the chance of progressing is very uncommon, and I actually disagree with that. I think it's actually much more common if you follow them carefully. And this patient had significant worsening over 2 years and 10 months in their late 40s. You can see the original ones in the middle. They came back almost 3 years later, and the difference map shows significant steepening centrally from progressive keratoconus. Now, we also want to follow a patient that had previous LASIK. This patient's right eye has already experienced post-LASIK ectasia. The left eye has this little suspicious area inferiorly, but at this point does not have ectasia. So we decided we're going to follow this patient over time. So in 2013, they had this little area inferiorly that we watched, this little irregularity, and they came back. We followed them every year, and finally by year 5, they had progressed enough that we felt it was time to cross-link. You can see that the inferior part got steeper. The difference map shows how that area got much steeper compared to the baseline. So now we have cross-linking available. It's FDA approved for keratoconus and post-LASIK ectasia. It is still considered off-label for occlusive marginal degeneration. The key is that it can actually stop the progression of keratoconus. It's quite effective. 98 to 99% successful with one treatment. And we often see improvement in the corneal shape and often improvement in vision following the cross-linking procedure. So here's a patient of mine that had the procedure done in 2011. You can see over time, from 2011 to 2016, there was significant flattening. The Kmax improved. The difference map shows that the steep part of the cornea got flatter, the flat part got steeper. This patient also experienced improvement in their vision. Now here's a patient, a 33-year-old patient, who actually at this point looks like they don't have keratoconus. It looks, their cornea shows symmetrical orthogonal astigmatism, no inferior steepening, but it's actually a trick. So this 33-year-old male patient who I saw in February actually already had cross-linking in 2017. They had this degree of keratoconus, and this is how they look 3 years later after the cross-linking procedure. And you can see the difference map clearly shows how the cornea reshaped over this time period. Now, what's interesting is that if you look even over more time periods, you see even more flattening. So this patient had cross-linking performed in 2014. They were part of a clinical trial. And they were at 15 months, they were significantly flatter. But then every time they kept coming back, they kept getting flatter and flatter. So over 5 years, they had 6 diopters of flattening. So in summary, these are just some keratoconus and cross-linking pearls. We want to identify keratoconus as early as possible. Children and young adults are at high risk of progression. Patients of any age can actually undergo cross-linking, and cross-linking can prevent progression. Often we see improvement in vision and corneal shape. Thank you so much.